So, coming back, we have a real treat for this last hour before lunch. I promise this is well worth it. Dr. David Snow is the program director at Loyola in Chicago and is a dear friend of mine. He has given this talk now for a number of years, and it is always like the most requested one to return. And I'm not sure if it's even that good, but the Scottish brog that he has is unreal, and people will just listen to him talk, like read the dictionary at this point. So, but seriously, this is an awesome talk because I guarantee you at some point during your chief year, someone's going to trigger you that you are leading. And you got to lead through that. And he's going to coach you how to do that now over the next hour. So take it away, Dave.
All right. You guys hear me okay? All right. So I ramble, I mumble. There's an accent. You guys are in for a treat. So as Matt says, I'm David Snow. I'm the PD at a newer program in the Chicagoland area. I was an APD for about 5 years before that and a chief before that. So about 9 or 10 years in residency leadership. That in no way makes me an expert in these things. I was going to title this at some point, the problem resident. And I don't like that as a title because I think that implies that the issues that you may come across as a chief are the fault of the residents in your program. And that's not necessarily the case. So the problem with residents seems like a less in-your-face title. My outline is pretty simple. There's 4 cases. I'm going to introduce them, and then we're going to talk about them in detail. It's a pretty simple outline. Let's get into these cases. Now, these cases, in some way, shape, or form, are things that I've dealt with in my time in residency leadership. So I hope that you guys don't have to deal with this, but the statistics tell me that some people at these tables are going to be faced with these situations. Now, there's going to be some repetitive themes too. I'm just going to throw that out there so it's not in the feedback. Put it in the feedback. It's all good. But I repeat myself a lot with some of these themes that we're going to talk about. So case 1, you're working a clinical shift. You've got a second year who's not carrying their weight. The off-service resident has more patients than them. And it's not the first time this has been noted, all right? This is where we're going with this stuff. Stay with me. Case 2, you're working another shift. Why are you working so much? A senior resident appears hungover. Now, I'm not talking about right now because you might have gone to Bourbon Street last night. I didn't. I was in bed early. So a nurse approaches you. The patient's commented on the smell of alcohol. Case 3. It doesn't get any better. Enjoying a day off, a co-resident sends you a screenshot of a resident's tweet, and it contains some protected information, some disparaging stuff, and they call you. Case 4, enjoying another day off, and you learn that the wife of one of your residents has died, and it's a sudden and unexpected death. Now, you got to start working through that stuff too. Okay. The things I'm going to focus on with all of you is what do you think your next steps would be? And then along with that, what do you think you would see your role as chief in these situations? So I'm going to pause during these when I bring them back up. If anyone's brave enough to engage, we'll find you with a microphone and we'll talk through it. I'm not cruel. I'm not going to call anyone out. I might call out my residents who have bravely sat in the front, but I won't.
I will.
And like as you read through these cases, like that title image that I had up there is probably pretty appropriate, you know? And there's a reason that we talk about these things, and I think there's a reason that it's important to have, at least to start thinking through a strategy for these stuff. And the reason that I think, one of the overarching reasons that I think the chief role is so crucial is because you will find yourself in a position to really influence the success of the residents around you. Like you're going to be the people. You are now, by design, by peer selection, you are the benchmark for your co-residents' success. When they think about success as a resident, they think about you guys. And that's a very, very powerful role to be in. And you can just kind of skirt through the next year and pawn everything off on your PD, which is completely appropriate to do. Don't think in any way the purpose of my talk is to say do all the work while I just sit in the back. But it's an immense role. It really is. And these times of adversity, I think, are when people's leadership styles and the influence that they can have on their program really comes to the forefront. All right, so case one. And I'll introduce it again. I'll pause for about a minute, just have a little think about it, and if you're brave enough, let's talk about it. So, working a clinical shift, second year's not pulling their weight, off-service residents seeing more patients, whatever I need to do to drive home what's going on here. And it's not the first time this has been noted. So again, think about what are your next steps, and what your role as chief. So just take a minute. Okay. All right, guys. Anyone? Oh, look at that straight away. Fantastic. You're going to get some steps in today, Dr. Holland.
So I guess, speak for the table, so let me know if you have something else. But we were talking about that we deal with this. We have actually dealt with this at our program before we were chiefs with somebody in our program. And so we approached the person, talked to them, and said, like, is there something we can help you with? You know, like trying to figure out, like he said, if there's an extenuating circumstance, or is there a reason that maybe they're not pulling their weight? And then Dr. Greg Lauren here said that if you notice that somebody's not pulling their weight, you can kind of be like, do you want to see this patient or this patient? Like, you're going to see a patient, but like, here's your options. You can choose. Yeah, broccolis or peas.
That's a very pediatrician thing. Do you want me to look in your left ear or your right ear first? Not, can I look in your ear? It's a false choice.
Yeah, these are skills that I'm learning as a parent of 3 young kids. Yeah, so thank you. Firstly, I feel like the first time someone speaks, like we've broken through a barrier. So now, if that's the last time someone speaks up, that's okay. I'm not judging you guys. I'm still taking it as a win because it's all about me and my success. So, but I love the fact that the very first thing is that resident okay? Because I think what can happen, with full-time clinical faculty is like, come on, like, pull your weight. What are you doing? Look at this off-service resident. You suck, and I think it behooves all of us to have that knowledge of that leadership role and be thinking about, like, we're there to help make sure that they are successful. So then, by design, let's make sure this isn't like the first manifestation of something that is a signal that something's wrong. Now, that's very important. I think also, you could take the approach on this that it's like, that's my PD's job. I'm not going to involve myself in this at all. This is a co-resident. That's a clinical thing. I'm going to focus on other stuff. And that's okay. That's fine. That is what it is. But again, as I'm going to sort of drive home, at least attempt to, I think there's real opportunity to be really, really crucial to success of your residents in situations like these. So I think if you use your role appropriately, I think the first thing is you know, in any situation like this, whichever sort of situation we can spin out that scenario, figuring out, is this actually a thing, is probably the first thing that I would do, you know? And the case sort of alludes to the fact that this is a thing, and it's not just, you know, they're having a bad day and they're a little bit tired or something like that. But digging in, talk to those that you know and trust. Talk to the faculty that you've been developing relationships with for the last 2 or 3 years. And we're gonna talk about why stuff like that, those relationships, are so important. And then, is it a known issue, as I've said? And again, like coming back to that first point, like, is there something more? Now, when you sit down and you have that talk as a chief, that's a hard thing to do, right? That's a very uncomfortable thing to bring up, right? Because you're essentially saying, I've noticed the fact that you kind of suck clinically right now. So let's talk about that. Now, in order to do that well, I feel like the only way that those sort of messages, those sort of conversations can happen in a productive manner is if there's respect. And that's an organic entity that just comes with time. So I'm very deliberate in my approach. Again, by no means am I an expert in this stuff. But trying to avoid like any formal discussion that you have with a resident being some sort of punitive thing or let's do this better. Take the time over these next few months to start building these relationships with your residents. If you have an office, you have an open door policy. You know, you try and carve out time in conference to have some sessions with your residents where they can come to you with issues. That then makes the times where you start having these sort of discussions a lot better. Because then they know very deliberately, but it's a win-win, that you're not someone whose only role is to call out the BS. Like, they know that you're there to help them and help them be successful. These are really, really important things, and they take time. Now, obviously, with this scenario, there's a plan of action that needs to be put in place. Let's take the fact that it's not some sort of substance abuse or mental health issue or something like that. But this is basically down to something clinically. You know, either they had a bad case a couple of shifts ago, or they're struggling with documentation, or they've been getting out too late. All the things that if I asked you what could be causing this, you would come up with the same things that I have. But once that's in place, that's probably at program leadership level in terms of the attending program leadership level, because we're all in program leadership now, that they come up with a plan. But where I see a chief's role in this is really helping with the afters of that stuff. Like, I'm here to help you. I know that we've now talked about this. I imagine that you've talked to the PD about this. Let's check in on this. Again, like it's that sort of central message that I'm here to help you. That's it. We're residents together, and I'm here to help you. I feel like the chief role in this is so much about that theme of resident well-being and resident support. And again, this is going to be something that I harp on and really dig into a lot over the next 20 or 30 minutes. And I'm also going to talk about some key points. And this is one that I'll say a lot. And I've already said it, so I'm saying it now for the second time. We'll probably get to like 6 or 7 times saying this. But the relationships that you start to carve out with the residents might be the most powerful thing that you can do as chiefs. When I was thinking about making the step up, across, down, however you want to say it, to PD, there's a guy called Tim Erickson at UIC who was a PD maybe 10 years before I even got there. But there were still people that would come up to me and say, like, if you want to do it good, do it like Dr. Erickson. And they'd been out and practicing for years, and he was just like, he's one of these guys that just universally, completely loved and respected. So I was fortunate enough, he was still at UIC at the time, so I carved out a meeting with him. And I just said, like, how do you do that? How do you become someone that, despite all of the ups and downs of residency and holding people to standards and, your in-training wasn't good and we need to focus on that, and, I heard about this evaluation, that wasn't great, you need to do better. Like all these ups and downs of program leadership, how can you be so universally loved and like truly universally loved? And he said it basically came down to one thing. He said, the more you know the residents, know them inside and out, know what they like and don't like, what their support system is, what drives them, the more you know them, the better off you'll be in leadership. And it's something that's stuck with me because we talked about how he did that. And, he wasn't aggressive and, friending them on Facebook and try to find pictures and all that kind of stuff. It was just, it's a very pure and honest thing that I don't think that we talk about nearly enough. Now, there's going to be times where, and I'm not saying at all that if there's social events that you always need to go to those or anything like that, but if you've stayed away from certain interactions and gatherings, I think now's a year where maybe you just start going to some of those. You just start getting to know people. You don't force the issue, right? If you don't want to do it, then don't do it. But I guarantee you, just by being present, you'll start to develop these relationships. When someone comes up to you, a resident, and says, I got to talk to you about this, that then becomes the single most important thing that you can possibly do in that moment. You take that in, you tell them, hey, thanks so much for coming up and speaking to me. If you're able to act on it, phenomenal. Because then when you can go back to them and say, hey, remember that time a couple of weeks ago, whatever it was, you came up and you mentioned this, I talked to someone about this, now this is what we're going to do. That might be one of the most powerful things that you can do in leadership. Because then people know that they're heard and that you're going to respond to it. And that's when the wheel starts really turning. Word can get out about that kind of stuff, that here's someone who really cares about us. So really be deliberate in how you start to develop the relationships with your co-residents. There may be some where it's like, I just don't like this person. Well, tough. That might be the most important person for you to start to develop a relationship with. Okay. Case one. Any thoughts, any questions? Please. Oh, law here. Beautiful. Oh.
It's like a little less encouraging and more maybe condescending. So she said, what if it's somebody in your home class that's harder than if it's somebody who's junior to you? Is that a quick summary? Okay.
I couldn't agree more. I feel like some of the hardest situations for chiefs is dealing with stuff as it relates to people at their level of training, right? There couldn't be anything harder than that. And I don't think it's inappropriate if you take the stance, I don't know if I should be the one to do this. That's absolutely 100% okay to involve the APDs and the PDs to do that. I think so much of that stuff depends on the relationship. And that's a very complex thing, because they might be friends where you're questioning, like, is this going to impact our friendship? And that's the beauty of it. You always have people right now that are a level above. We're all part of the same team, but from a hierarchy standpoint that you can engage with them. The junior residents, I feel like so much of the time there's just something that they need help with. Like there's something that's on the face of things is a little bit simpler. It's like I'm scared to pick up more because I fell behind in my documentation. It's like, okay, let's talk about that. Here are some strategies that I have to make the EMR work for me. Some dot phrases depending on your EMR, that kind of stuff. It tends to get a little bit more complex the further along you are in residency, and that's where things like work ethic and drive and stuff like that really come into it. So every case is going to be a little bit different, but again, if you feel that I need to step back from this and just make my attending program leadership aware, I think that's completely okay to do. Please.
Yeah, so we're at a 4-year program, and my co-chiefs and I have been tossing around the concept of like punitive responses to things, and whether like when the role is there to, over the last 3 years, we've kind of seen and heard different versions of like, hey, if you aren't prepared for this procedure, you're going to get bumped, or if you can't, like, if you're about to run the code and you can't tell me like what doses you're going to have as your like first couple of things that you're going to set up, like you're going to be moved to a different area or whatever the case may be. We've heard all these things, and we're having like kind of morale issues with some of our lower classes with COVID, et cetera. It's all complicated, but I think we're tossing around the ideas of like, how do we maybe bring back some version, if you identify that there's no obvious like terrible thing that's going on in this person's life that you're about to like blow up, but that there's a not prepared, that the issue is like unpreparedness or not, a work ethic issue or whatever the case may be. How do you balance that kind of like delving a little bit or like flirting with the idea of punitive responses coming from like the chiefs or the fours, to like set a tone or expectation in a way that's like, not toxic to the entire residency, but it's also toxic to have poor work ethic in the department right now too.
Yeah, and the punitive stuff is really challenging. I remember when I got to my first attending job and I was an APD, I was noticing that people would just turn up whenever to conference, and then they would be kept after graduation to make up conference time, and I was like, what's going on here? And one of the first things I did was enact this: if you're late a few times, you get an extra shift. And, I came off multiple people's Christmas card list at that point in time. And I think the decision on whether to enforce punitive stuff, I think it's sort of like, it's a very last line of defense against that. Because I think for some of this clinical stuff, if we take the patients per hour, or let's use your example of the code. If you can't come up with some of the first steps, I can't let you run that code. Is that hitting at something specific with that resident? Now, you're talking about some morale and cultural stuff and stuff like that. That is, man, that might be a 5-hour session in and of itself. But I think if morale is already taking a wee bit of a hit, the punitive stuff is going to just like tank that. There's no doubt about that at all. And I wonder if, and this is like very superficially knowing about it, I felt like the mistake I made with kind of jumping to a punitive action was, like, what was actually going on? And it was just that, a lot of times the 8 a.m. lecturer was running late, or 7 a.m. for where I was. So then they were like, okay, well, I'm just going to start showing up late. The first hour kind of sucked. So they were like, well, I don't have any reason to be there then, and they're probably going to be late, so I'm going to be late. And then there was no accountability for stuff. Now, those are some pretty, they're not simple, but simpler things to put in place that then benefit everyone. And I think what I then did was talk to the residents about what the expectations were as it pertained to conference. There's an ACGME minimum. We have to be aware of that. If not, we'll get a citation. You may not have a residency anymore. Let's get some feedback. Why is the feedback falling off that no one feels like they can tell us that the first hour almost universally sucked? There was a lot of things that I felt like I could have done better before jumping to the punitive side. And I feel like what I've tried to do, and this again is down to time and resources for those instances that you bring up, is there a way for me to use the team whose job it is at its core to make sure that every resident is successful and graduates with the skills needed to be a successful attending? Is there a way to take those instances and say, okay, I've now identified that you're having issues running this code. Now, because of that, let's do it together, and if I feel like the patient's going to be worse off, I'm stepping in, but at some point over the next short period of time, we're going to engage in this in a simulated session or something like that. Not because I need to, not because it's punitive. This is just for you to succeed. I think when you start spinning those wheels a lot more, I just feel like the perception changes. That's so much of what it is. I feel like what can happen with the punitive stuff is people start to feel like you guys are just bookkeepers, you know? It's like checks and balances. You didn't show up, you get an extra shift, you know? You bomb the in training, you're immediately on remediation. You have to do 4,000 questions every month, you know? But if you frame it in such a way that, and again, you're helping me with this like central theme of those relationships with those residents are so crucial, because if they respect you and they feel like you're just there to help me, you can pretty much engage on any dialogue and any pathway and any algorithm, and they'll be a bit more responsive. It might not be perfect. I don't know. I'm notorious, as they'll tell you. I take a question, I have my version of an answer. Did that help at all? Okay. They know. They'll call me out on it. So I will not be offended if you do. Guys, I love the back and forth. This is beautiful. Because I know I'm right before lunch. I know what's going on. Okay. Case 2. You're working a clinical shift. One of your co-residents appears hungover. Nurse comes up to you. What do you do? Okay. Again, immediate next steps. And what do you feel like your role is? Just have a think about it. All right, guys. What do you guys think? It's pretty straightforward, right? Not a big deal. Okay. So one of your co-residents is actively hungover and probably still drunk.
I think
Anyone?
the immediate action for us is to put patient safety first. Like essentially you have to send that senior resident home, and you have to activate backup, and you have to cover their shifts. The other thing is, I think addressing the substance use is, and our alcohol use is, I think, a more difficult conversation, and it's honestly something that, as chief residents, I don't think we should address alone. I think that has to be in conjunction with our program leadership.
Yeah. Love it. Thank you. Thank you. A hand up here, Dr. Holland. Couldn't agree with those sentiments more.
So we were trying to talk about the nuances of how to actually approach the, like, you need to go home, and we acknowledge that after that part is taken care of, your PD, your APDs should take over in terms of addressing the larger stuff. But I think the approach that I would like to take would be to say, like, not accuse, and just say, look, something's going on. You can't work right now. I can tell that, you know, you're not in the right shape to work, and I need you to send your patients out to me, and I need you to go home. We'll talk about it afterwards. But with it not saying, like, look, man, are you drunk?
No.
You know?
I agree. And yeah, the sort of initial communication aspect might be the most challenging piece of this, right? And like, who should do it? I think, if not the first step, one of the first steps is calling the PD and making them aware of the situation, right? It's a massive deal. Anything that's potentially career-threatening, patient harm stuff, Like, that's the stuff that gets you kicked out of medicine, fired, booted out of residency. Hospital leadership, GME, start learning about this stuff. It's got potential to end someone's career. You know, as noted, that person, obviously, they have to go home. And I feel like as a chief resident, that's a very challenging discussion to have. I feel like it's completely appropriate. If I was to tell someone this is how I think you should do it, is to have the attending handle that. Now, if your PD is close by, that's okay too, because they're going to know about it pretty quickly, as well they should. But that person needs to go home. And how that discussion happens, again, it's a central theme. Snow loves to repeat himself. I think if you've cultivated and developed those relationships so that people know that it's not punitive, I'm just worried about you. Are we good? I think you can have that conversation in such a way that people don't feel that you're coming at them. Now, invariably, they probably will, because that's in essence what's happening. But it's like, if they see you as someone who really cares about their success and has made that time to be that person in the residency, as I hope that you guys do over the next few months, again, it makes these conversations that much more powerful. And it's the sitting down and talking, and it might not be, again, for the chiefs initially, again, it's that follow-up piece. Like, it really is. You know, you may not feel comfortable, and I totally understand it, because I'm not going to be comfortable going up to a resident and having this discussion, but I understand that if I don't do it, no one's doing it, and that can't happen. But it's that afters, whether it's later that day, whether it's the next day. How are we doing? Is everything okay? Again, I'm not here to judge you. I just know that residency is hard. Sometimes we make stupid decisions, and I want to know that you know that if you need anything, if you want to call, if you want to text, let's chat. Let's meet for a coffee. You know, like you ask a question where there really is only one answer. Let's go do this. Little inflection. Oh, I have a choice in this. But the answer is actually yes. Okay, we're going to meet. Again, the chief's role in this, I feel like, involve the PD and then that resident support. Now, can I take these cases and flesh everything out that needs to be done? No, of course I can't. But if we come back to these themes of how they see you and they see those interactions, and you don't just walk up to someone on shift, hey, are you drunk, as was said, right? Which, you know, was obviously stated as to not do that. Thinking about how you engage in communication, I think, is something that's central to any physician overall. Like, what do I hope to gain from this interaction? Is like a beautiful way to think about any communication that you have. So then if you think through this, there's no way that walking up in a clinical shift and just coming out is going to be the right thing to do. But be strategic in how you have these conversations. Is it best to drive to their house? Is that a bit too impersonal? Do you know them well enough to do that? I've heard about cases where, you know, resident didn't show up to a shift and the police were called and they show up and they were only like 45 minutes late. That's guns blazing kind of stuff, you know? There's a perception on how that's received. Like, thinking about how your communication is going to be received might be one of the things I think about more than any others as it pertains to communication. Am I great at it? Absolutely not. But at least I try, you know? Okay. Any other thoughts? Any other questions, please? The key point in this, though, there was one thing that I skipped past, and that's the fact that a nurse came up to you and told you something. Now, that's an incredible thing. Now, I'm one of these people. I draw these imaginary lines in my day, and up until the point where I became a PD, I became known as the guy that when he was on shift, just leave him alone. Just leave him alone. He's there to take care of patients. Leave him alone. And I thought that was a good thing, because I'd seen program leadership, department leadership be on shift, and you couldn't get a word with them because they were answering phone calls. They had a laptop out. Like, who has a laptop out on shift? I still can't understand that, you know, unless they're going to give a lecture at some point in the shift. I don't know. But I'd drawn this imaginary line, and it would piss me off when a faculty, this is ridiculous to say out loud, but it's 100% true. If a faculty member came up and said, hey, Snow, I got to talk to you about something, I would be like, oh, you asshole. I'm here to take care of patients. That's where my head was at. And I've started to realize pretty quickly, I need these people. They are the eyes and ears, much like you guys are, but it's a much better relationship, I feel like, because it's defined and we know, like, we're here for each other. Like, the fact that all the clinical staff are absolutely crucial to your next year. And the more that you engage with the nurses, the techs, the more that you see these clinical faculty, the ones that they don't show up to conference, but they're sure as hell in the department seeing patients, you need them. And the more that you can start to engage with them, if they come up to you, that, again, much like when a resident does it, is the single most important thing at that moment in time. And that's how I've had to sort of change my perception. Because I just thought, in program leadership, I operated in this silo. You guys do that, I do this. But everyone is in this together. And if a nurse feels comfortable coming up to you and telling you something, and you can't say thanks enough. I worked a shift about a month ago, and the case manager, as I was packing up my bag to leave, she turned around and she said, "Hey, Snow, I'm worried about this resident. I've just noticed their demeanor. I don't even know if I should tell you, but I noticed their demeanor a couple of times, and I'm kind of worried about them." I couldn't have thanked Betty enough in that moment. I was like, you can always come to me with this stuff. I'm not going to judge anything. I'm not going to jump to any conclusions, but thank you. And I talked to that resident. Everything was fine. I didn't say, "Hey, Betty came up. She's worried about you," you know. But getting these little snippets of information, I think, are really crucial. And then empowering those people to do it again. The relationships you have with all the clinical staff can't do anything but help you succeed. Okay, we're 2 cases in. We're halfway. Case 3, maybe. There we go. All right, as you see it, someone's up to no good on social media. And I don't know, like Facebook, I guess, could do this. Twitter could do this. Snapchat could do this. I have no idea what Snapchat is. Someone's Snapchatting something where there's PPI and disparaging stuff. There was something that may or may not have been at my institution in the last few months where someone posted something on Reddit about, it was actually an email from their program leadership about how pissed off they were about this communication. I've never heard of that before either. It's on Reddit, but this is what we deal with. Some people just make poor choices, and it's up to us to help them with those choices. But you get this, you're the person who hears about this. Take a minute, think about how you're going to handle that situation. All right, guys. Admittedly, a little bit easier to work through than the last one. Who wants to relieve me from speaking for a minute? Relieve you guys from listening to me speak for a minute.
I got one back here.
Please.
I mean, this is pretty clearly an immediate phone call and a what the hell are you thinking, take that down. But the more interesting thing to me is the disparaging comments about the patient. And that's the thing that I kind of want to get to the bottom of. That's where I want to ask the open-ended questions, see what's going on. Anti-empathetic responses are almost never about that person actually lacking empathy, but what is going on in their sphere that's driving them to that place.
I love it. I really do. Because again, it's like, you may get this this text, this phone call, and be like, huh, it was only a matter of time before they did that, you know? Or it might like catch you off guard, you know? And I think it's really easy just to kick into this, what the hell are you doing? Because it's so obviously wrong. You know, in every spectrum of whatever algorithm that you're going down, that decision was incorrect. Now, this stuff happens. There was a doc in Chicago just a few years ago who there was a drunk, younger female, early 20s, in a hallway bed, and they thought, this is a good idea, what I'm about to do. I'm going to take pictures of them and post it to social media with some disparaging comments about them. Like, what are you doing? Let's have a talk about what's going on in your head right now. Now, social media to me is like one of the most interesting things. I, by design, because I'm very like, you know, I'm passionate about certain things. I hate social media. I think it's just designed for people to mess up and then be judged by the world. But I've seen and read there are cases out there where doctors have had to answer to hospital leadership because they've liked posts. Just a like, just a click of a button. So as we superficially, because of time, dig into this, just be mindful, right? You guys know this. I'm preaching to the choir. Just think about, again, what's the goal of this communication right now? I'm liking this potentially controversial post. Might this be seen in a different light? It's not really about that, but I'm just saying, Big Brother David Snow is just giving you a piece of advice because I've seen people, I've heard of hospital groups come at physicians because of that kind of stuff. Now this one, again, beautifully stated. What's going on with that resident? Now again, repetitive. If they respect you, if they see you as someone who's made time for them, if they see you as someone who's there for their success, it will be seen in a different light. I agree with everything that was said. It's talking to them. Hey, what's going on? That might be a phone call. That post is gone. Please take it down. Now, that one with the Reddit post, is that a deeper thing? Is that a morale thing? Is that a cultural thing within the residency? All things that are very, very difficult to parse through off a single social media snafu. But it's that bigger picture that was so eloquently put of what's going on there. There's disparaging stuff. Now, let's take some time and work through that. The PD needs to know, right? Again, this is stuff easy. It's potentially career-threatening. Because GME offices, they probably have some kind of social media policy on this. I imagine that at all of your institutions, they do. And this is where the PD has to come in and just talk about that. Every time I give this session, I think about the fact that I've never actually talked to my residents about the social media policy that exists. And I'm reminded maybe I should do that before there is an issue. But they will take a very, very stern approach to this with the residents. So again, that central theme, the chief role is awareness of resident behaviors. Like boots on the ground. What's going on with these people? If you're willing to engage in these discussions with residents, it is absolutely appropriate to do that. There's just something, despite my best attempts to be a PD that people are comfortable with, there's just something different when it's like, hey, let's meet and talk. Immediately, despite my best intentions, it's like, ooh, what did I do? I can see it in people's eyes when I do it. I'm like, I just want to check in. You're getting married in 2 weeks. Let's talk about this. Like, why? Are my shifts too low? Do I need to make up time after? This is where they won't feel that as much with you guys. So it's such a powerful role in that resident support piece. And again, this is the same slides I had after case 1, relationships. Work on them. All right, case 4, if there's no other thoughts or questions. All right, we're going to end with a darker one. Resident's wife dies. A loved one dies, whatever it is. Get in a horrendous accident, and they're in the ICUs. They're intubated. Whatever it is, there's some derivative of this that unfortunately you guys are going to encounter this year. It's a sudden and unexpected event. Some first steps to this horrendous situation. Just take a minute to think about it. All right, guys. Anyone want to start thinking through this? Please. Go right here.
Up to the front.
Yeah.
Yeah, so I felt like when we discussed this case, as tragic and as difficult as it is, it almost seemed to be the easiest answer for us. And it's calling them, taking them off work, saying, what do you need? We're going to cover you. We're going to take you off. We're going to support you in any way we can. If you're not their closest friend or closest resident, you make sure to reach out to leadership. You make sure to reach out to who they feel most supported by. Make sure that they get checked in on. Make sure they have childcare. Make sure they have, to me, that I feel like this case is one where it's not just a chief role, but this is your family role.
Love it.
And I think that is what makes this case the easiest, even though it's very gut-wrenching.
Yeah. I couldn't agree with that sentiment more. Please.
Thank you. Definitely we share the same ideas and the sentiments, you already mentioned. But we also brought about a different possibility, that, when things happen, as tragic as they may be, you reach out to them and say, hey, how best can we support you through this? Also opening yourself to the possibility that the individual might say, hey, don't pull me off of shift, right? What if I want to keep working as a way to cope through this? And this is more of a question to the group, right? Do you insist and be like, no, you're going to jeopardize patient care, you need to get out and, take some time off. But now I know the death is more of like an extreme example, but you kind of consider chronic illness or unexpected, like a cancer diagnosis, for example. In certain senses, it might be best for the person to say, you know what, maybe keeping busy right now is good for me, right? I don't want to go sit in a dark room and wallow away. So I guess I want to see what the rest of the group thinks about that possibility. Do you force a time off on them if that's not really what they want in that moment in time?
I want to give others a chance to answer your question, but another point that we were just talking about in our small group was respecting their privacy. So that's kind of going to be a little tricky component, because if they just reach out to the chiefs and just tell us hey, this tragic thing just happened, how do we respect their privacy and not tell the rest of the residency, even though people will eventually find out? And I think we just kind of have to ask them, how can we best support you, like everyone was saying, and privacy should be a component of that conversation too. Because in residency, everyone wants to reach out to them and ask them if they're doing okay, and but they may not want that. So.
Somebody over here.
So to answer your question, I think just really emphasizing what do you want. So at that moment right there, finding out that someone's relative died, a parent died, I'd be highly surprised if they want to still work that day, right? But if they, but moving forward, just asking them what they want. Some people cope with pain differently. Some people want to stay busy. So if that's the case, if they only need 1 or 2 days off, so be it. Just really opening the question, what do you want? And emphasizing work is always going to be there, but you need to handle your family business first. So yeah.
Man, and I feel like we could, this just, it brings up so many emotions, and all of these points they're incredible. They really are. Every case is different. I couldn't agree with that more. Extreme one like this, they're off the schedule. 100% for me. They're working through the grief piece, and you can't do that in our job. It's just, it's too challenging. And then the respect and the privacy, I couldn't agree more. Again, it comes down to that relationship, me being able to say to them, look, we're going to keep this between us, but people are probably going to find out. So just be prepared for your crew around you to be reaching out. But I'm not broadcasting this, but you know what's probably going to happen here, because this is too big a deal. It's just it's acknowledging it exactly like you're talking about. I think it's a really powerful thing. Please.
Yeah, I think the points that have been brought up are really good. I just wanted to share, because I personally had to deal with this. I had a cancer diagnosis 2 hours before a shift, and the Chiefs did amazing, and they were there for me. They canceled my shifts for the next couple days, and that's what you have to do initially. It's just be there for them, and then kind of hands off, right? Like privacy, just letting them know that you're there was all I really needed, and then they need to take the steps to talk to admin and administration about scheduling, and then later, when you're ready to have the conversations about the rest of the year, what does it look like any other, like HR, do you need to take leave? You know, there's a lot of components that are part of this, and so there's an initial reaction, and then there's a lot of planning that goes into this, and this is part of the chief role, and I think, taking on that, and then what you had mentioned about privacy and letting other people know, that's up to the person, right? So like we had a discussion of how I was going to let people know, and I let people know on my terms, because that really should be on the person's terms on their own. So
Incredible. Thank you so much for sharing that too, right? I feel like there's nothing better than these examples where it's like, I lived through this, and this is what worked really well, you know? Please, Dr. Holland.
Were you chief when Ali Delgado had her accident?
Yeah, so one of my co-residents, their wife, the scenario is ridiculous, really, when you parse through it. So we do flight shifts. We did flight shifts during our residency, and their wife was critically injured. Cycling, had a helmet on, horrendous subarachnoid traumatic bleed, intubated for several weeks, ICU. I could go on and on about this story. Dr. Delgado was actually the flight doc who responded to her scene, saw her intubated in the small ED at the time. She was then discharged. This is all out there. She's written a book about this, Ali Delgado. You know, she got sent home. She then seized. He was worried about her airway. She had been trached. He was able to get the trach back in with a lot of blood. There's so many incredible, outrageous scenarios from this, working through that and watching our program leadership just essentially circle around. It's one of the most incredible things to watch in these horrendous moments. And all of you, it's all correct. You know, I feel like personally, the reason that a lot of people will say, just keep me on the schedule, is because we kind of suck at this. You know, it's and this is pre-COVID, I feel like, it was yeah, I may or may not be having a heart attack, but I don't want someone to have to come in and cover this shift, so we'll just work through it, you know? It's almost like you have to throw it out there for them. You're off the schedule. We're good. We'll handle this. And then if they kick back on that, now let's work through it. Now, this kind of scenario where it's a loved one that's died, we're not even talking about that. I respect where you're coming from, but you got to take some time. Now, for some of these other situations, absolutely. But it's that understanding that this is not a problem, but you're off the schedule. The theme that I'm going to kind of end with here is this stepping up. With leadership, I think invariably there comes sacrifice. And you may end up, for these situations, having to go in and do some shifts on a rotation where you're like, oh man, I already did that, I don't want to do it again. You may have to pick up shifts in order for people to go to certain events to be with their co-residents. And that's really hard. There's a lot of things that will come from events like this where you do it, you don't talk about it, it might not even be recognized. There's a sacrifice piece, and I'm going to drive that home in just a couple of minutes. That family sort of coming together that's been talked about is an incredible thing. I've watched people rally around with meal plans and sending money to handle certain expenses. This can be very unifying for a residency, oddly enough. You know, it's an incredible thing to work through. And the reason that, and I'll end this, the chief role, if I say it, and obviously this isn't true to the form of the previous slides, your role in this is critical. And I think situations like this define why you became chiefs in the first place. You're just going to do things to help others get done what they need to do in their life. And the reason I'll share with you is, this is the only time I talk about this is during this session, and just seeing her face brings up memories. So Leah, Dr. Davis, she was a UIC resident, and I just worked a shift, and I got home. We didn't have kids at the time, so it was 11 o'clock, and I was awake, which is atypical now. Then I got a call from one of the chiefs. Hey, Leah didn't show up for a shift, and I was like, that's kind of weird. That's not Leah. So we stayed in touch for a couple of hours. By 1 a.m., it was like, ooh, something's not right. So I had to turn to my wife and say, I've got to drive about 20 miles to check in on this resident. And she's like, huh? What are you talking about, Snow? I was like, something's not right. Just had a gut feeling, you know? And then on the way there, my PD at the time said, Leah was found dead. She was found dead. She died in her sleep. And you're starting to work through that, you know? And we sectioned everyone off into groups, come into the hospital the next morning, and I had to tell Brad and I in different times, different groups, that their co-resident was dead, completely unexpectedly. Now, immediately, they're sent home. Now, immediately, we just started picking up shifts, you know, and the EDs that we worked in, like a lot of the ones you work in, they're staffed by residents, right? If there's no residents there, people are grumbling. Now, that's not what happened with this, but immediately we just started picking up shifts to help out the attendings. I'm not saying any of this to look for, hey, great job. That's completely against what I'm doing, but I feel like talking about these things sort of drives home why we do what we do, the impact of the role that you can have in these situations. And I remember one situation where I was stupidly training for a race, and it was like 2 days after, and I worked a shift, and I knew I had to come back and cover another shift the next morning at like 10 a.m., I knew I had this long run, so I got up at 3:30, and I'm running through the streets of Chicago, and it's really dark, and I'm like, what am I doing? I'm just an idiot, but I did it, and then I worked the shift, and the next few days just kind of went like that, where I was just disconnected, I was a mess. And outside of these sessions, I've never talked about it. Don't tell anyone about it. No one knows about it. No one came up and was like, hey, Snow, thanks for working those shifts, right? Not that I would in a million years expect them to. But leadership is about being that person who you need to be in these moments of real strife and hardship for those residents around you. I think about Leah all the time too. I hope that you don't have to deal with these situations. But again, statistics tells us that at some point, someone in this room is going to have to. And just know that, like was said, the whole team will come around you guys to help with that. But that sacrifice piece, I think, is one of the most beautiful things about being in a leadership role. So to review, develop the relationships, the residents, the nurses, the ancillary staff, the clinical faculty, be the PD's eyes and ears. Please, just like cultivate those things. Be those people that is just going to help us, help each other, help the residents. Be prepared to sacrifice and know your role is crucial to the success of the residency. It's an amazing year. It's an amazing role that you guys have. So thank you for allowing me to take this time to talk to you. I'll happily answer any questions, but I wish you guys all the best for the year ahead. Thanks.